Thank you for Thrombosis UK giving me the opportunity to present today. I'm presenting a topic that's sort of quite close to my heart at the moment with regard to reversing oral anticoagulants and focusing particularly on Andexanet Alfa. This is VTE from a Scottish perspective, and I think we're seen south of the border as being very lucky that we are able to use Andexanet for more indications than can be done in England. And I suppose what I want to indicate, this is possibly a double-edged sword, and has given us led to lots of head scratching. So just to give an overview of the talk, I'm going to talk about what's available there to reverse anticoagulation. I'm going to talk about prothrombin complex concentrates, Idarucizumab, Andexanet Alfa, and give some thoughts about are these ideal reversal agents? What evidence is out there? Are they good? Are they doing what we want them to do? And then talk a little bit about what makes us hesitate to use Andexanet Alfa. Maybe that's not the experience of all of you, but it's certainly the experience that we are having in our health board in Greater Glasgow and Clyde. So first of all, let's talk about what's the ideal anticoagulant. So you can see down here on the left-hand side, you want an anticoagulant to work, to prevent venous thrombosis, or you want it to be a tablet for the benefit of the patients, if nothing else. You want it to work quickly. You want it to have a short half-life, so there is a bleeding problem, it's going to be out the system quickly. You want it to have a predictable pharmacokinetics, have minimal drug and food interactions, and be fully reversible. And you can see here that Warfarin, although we've been using it for 70, 80 years, it's highly effective. It really has its issues. It doesn't act quickly. It interacts with all sorts of food and drugs, but fortunately it is fully reversible. However, our new direct oral anticoagulants, although obviously not new now, they've been around for 10 odd years, are absolutely brilliant in many respects compared to Warfarin, but until 2016 couldn't be effectively reversed. So on the opposite side of that, what is the ideal reversal agent? Well, you want it to be effective, no matter what the bleeding severity or the level of anticoagulant. You want it to work quickly. You really want it to have a similar half-life to the anticoagulant that you're trying to reverse, because if it has a much shorter half-life, the anticoagulant effect could come back. If it has a very long half-life, it may be difficult to re-anticoagulate the patient. You also want it to not be prothrombotic. You don't want, by the effect of switching off the anticoagulant, to make that patient more prothrombotic. Now, obviously, the patient is going to be at thrombotic potential because they're on anticoagulation for a reason, but you want to make sure that you don't go over and above that. And I think finally, we've got to be realistic. We're in the NHS. We don't really want it to be too expensive either. So I'm really going to go over the basics here. I think it's good just to recap on Warfarin and how we can reverse that. So just to give us a little bit of revision, Warfarin's vitamin K antagonist. It interferes with the function of the vitamin K dependent factors, which are 2, 7, 9, and 10. And we measure the effect of Warfarin using the INR. Warfarin has a really long half-life. It hangs around for many days, and its half-life is around about 40 hours. A little bit of the duration of the effect of the Warfarin is dependent on the half-life of factors that it interacts with. Factor 7 has a really, really short half-life of 2 hours, but factor 2 has a half-life heading towards 4 days. And we're able to assess the effect on hemostasis really quite well with Warfarin. When someone does present with bleeding, how bad is the bleeding? And we can check the INR level to know how much of an effect the Warfarin is happening, which perhaps makes it a little bit easier to reverse. So really, when I'm talking about, when I'm in this talk today, I'm really talking about, really bad bleeding. I'm not talking about the sort of bleeding where you can simply just stop the Warfarin or give a little bit of vitamin K. I'm talking about major life-threatening bleeding. And we have known for probably about 20 years now that for major life-threatening bleeding or urgent surgery, prothrombin complex concentrates. In your health board, you might use Octaplex or Beriplex. These have been demonstrated eventually in a randomized controlled trial 10 years ago now, that these which contain all the vitamin K dependent factors are effective at reversing the effect of warfarin in the context of major bleeding. They allow quick reversal. Once the infusion's in, within about 10 minutes, the INR will be essentially back to normal. We also have to bear in mind it is a plasma-derived product, and that should always be made clear to the patient if it's possible to do so. And the dose is relatively clear. It's weight-based, so whatever the weight of the patient is, and it's INR-based. And you can see here a table that's come from one of our guidelines in Glasgow, that depending on what the INR is, you give a particular dose based on the patient's weight. You should always use it along with vitamin K intravenously, because the effect of the Beriplex or the Octaplex will start to wear off probably before the effect of the warfarin is gone, because of warfarin's half-life, prolonged half-life. And the vitamin K will be able to allow normal coagulation factors, normal vitamin K coagulation factors to be made. And the cost of this, roughly, depending on the weight of the patient, what their INR was, will be somewhere between about £1,000 and £3,000. So that's warfarin. What about the direct oral anticoagulants? How can we reverse them? Now, I'm just talking about, first of all, I'll begin talking about the factor 2A inhibitors. And we're here talking about dabigatran. I'm not talking here about argatroban or bivalirudin, just the oral dabigatran. We know this is very effective at treating venous thrombosis, preventing stroke in AF patients, and it is as effective as warfarin, and it carries about the same risk of major bleeding per year as warfarin does, about 1 to 2%. But I probably don't need to tell this audience, you don't get it used very much. It's nowhere near as popular as the other direct oral anticoagulants for probably a few reasons. It commonly causes dyspepsia. So, if you're using this in a patient with atrial fibrillation who's going to take it for the rest of their lives, they're not going to be happy with that symptom at all. And it's very common. If you're using it to treat venous thrombosis, you need to give 5 days of levodopa before the dabigatran starts. That was part of the clinical trial. And that makes it unpopular as well, where we're aiming for quite quick turnaround of patients in the ambulatory care units. And that's obviously more complicated if you're having to give a subcutaneous injection prior to starting dabigatran. And in the randomized controlled trials, there appear to be a possible increased risk of stroke and myocardial infarction when dabigatran was used compared to warfarin. So Idarucizumab, this was the first reversal agent for a direct oral anticoagulant, highly, highly effective. So it's a humanized monoclonal antibody, and you can probably see from this diagram here, it's got a very, very high affinity for dabigatran. So basically, rather than the dabigatran being able to slot into the factor 2A and inhibits its action, the monoclonal antibody coats the dabigatran and it can no longer bind. It's very, very specific, and it has no effect on other oral anticoagulants, no other effect on other anticoagulants. Now, the indication for Idarucizumab is life-threatening or uncontrolled bleeding. Interpret that as you will. And it's also indicated for emergency surgical procedures. It's 2 bolus doses, intravenous bolus doses, can be given as a short infusion. And it rapidly inhibits dabigatran. The plasma concentration, basically of dabigatran falls away very fast. And when you try to measure the effect using dilute thrombin time or eccrine clotting time, all patients in the study had these coagulation assays were corrected in everyone at 4 hours. And what's quite interesting about Idarucizumab is it slowly degrades. So its effect on dabigatran lasts for quite a long time. The dabigatran-Idarucizumab complex degrades very slowly, and the effect of Idarucizumab lasts for about 12 to 24 hours. And you can see here, just from this diagram from the pivotal study back in 2017, that based on the dilute thrombin time, both in Group A, which was the bleeding group, and Group B was the urgent surgery group, you can see there's an effect on diluted thrombin time when Dugitran's in place before you give Idarucizumab. You give the Idarucizumab, within 10 minutes, the DTT has return to normal range. The normal range is shown by the shaded area, and it takes a good 24 hours before any patients start climbing above that, back towards an abnormal range. What we've got to bear in mind, I'm going to mention this with all of these, is what was the clinical effect? Now, Group A, as you remember, is a bleeding group, so absolutely, completely clinician assessed, so subjective. How quickly did bleeding stop? In the study, it said within about 2.5 hours, everyone within 24 hours. But the cessation of bleeding was only assessed in less than half of the patients. There was no assessment in those who received Idarucizumab for intracranial hemorrhage and for the other non-specified bleeding. So that gives some cause for concern, a little bit of pause for thought. And then Group B, which was the surgical group, the surgeons, again, subjectively felt that almost all the patients achieved normal hemostasis. And the thing that's important here is there was no comparator arm for this study, and I'll talk a little bit about that more later. The cost, a little bit more than prothrombin complex concentrates. These are all estimates, or the cost of the NHS is always confidential, but roughly it's going to be around about £5,000. And then perhaps the most important area, and I'm obviously going to come on to talk about Andexanet, is the 10A inhibitors. Now, these are our most commonly used DOACs now, Apixaban, Rivaroxaban, Nadoxaban. What's quite interesting about these is their risk of major bleeding is lower than warfarin, certainly with Apixaban and Rivaroxaban, and probably at least half the risk of bleeding. Nadoxaban maybe a little bit less, but not quite as marked. So how does Andexanet Alfa work? Well, again, very, very interesting. Basically, it's basically a modified recombinant factor 10A, and it acts as a decoy. So rather than the 10A inhibitor, let's say Apixaban, for example, binding to the site here on the factor 10A that allows the conversion of prothrombin to thrombin, the 10A inhibitor will bind to Andexanet instead. Now, because it's so specific, it's slightly effective against all 10A inhibitors, but we still don't have enough formal evaluation for it to have yet received a license from fractionated heparin, low molecular heparin, or Nadoxaban. I'll talk a little bit more about that too. So in Scotland, Andexanet was licensed over 2 years ago now. Only licensed reversal of Apixaban and Rivaroxaban, only for uncontrolled and life-threatening bleeding. No license for surgery, and insufficient evidence, as I said, for other 10A inhibitors. In the trials, the dosing was based on the dose of the 10A inhibitor that was being used in the patient and the timing since the last dose. And what I'm also going to talk about is the dosing is not based on what the anti-10A level is before Andexanet is given or on the post-dosing anti-10A level, and I'll come on to that. So this is taken from our guidelines that we have in Glasgow, really just to point out to you how dosing is calculated. So what was the last dose that was taken? Was it more a therapeutic dose that you might use for atrial fibrillation or for a recent venous thrombosis, or is it a lower prophylactic dose? For example, Apixaban 2.5 milligrams twice a day. And then the timing of the last dose. Anyone who has been faced with these questions of such patients at the front door will know we often do not know when the last dose was taken. So they have a caveat here. If it's less than 8 hours or you don't know, greater than 8 hours, and then we don't use it after 18 hours because this was not included in the clinical trial. So what was the last dose? When was it last taken? And this then determines what dose you get, low dose or high dose. And whether it be low dose or high dose, you give an initial intravenous bolus, which takes roughly about 10 to 20 minutes to give. and then a continuous intravenous infusion, which takes 2 hours to give. And this is the data from the clinical trials. At the top, you've got the anti-10A levels. You can see that in the red line is when Andexanet was given. The black line is placebo. This was in healthy volunteers. And you can see a massive reduction in the anti-10A level very, very quickly. But once the infusion is stopped, the anti-10A level relatively rapidly comes up again. The two graphs below, again for apixaban and rivaroxaban, is looking at endogenous thrombin potential or thrombin generation, a marker of how effective the coagulation cascade is. You can see when Andexanet is given that there is a dramatic fall in, before Andexanet is given, there's a reduction in thrombin generation because the patient's on anticoagulation. When you give Andexanet, thrombin generation dramatically increases. And in fact, you can see a little bit of rivaroxaban, it actually seems to go above what would be considered the sort of normal range for thrombin generation. And then that increase in thrombin generation gradually returns to normal very soon after the infusion stops. Unfortunately, the real-world laboratory assessment of the effect of Andexanet is not possible. So what you're seeing there is the clinical trial in healthy volunteers where they had a specific in-house anti-10A assay. Because Andexanet reversibly binds to the FATS10A inhibitor, in our anti-10A assays that we use in the standard laboratory, they require significant dilution. And this then leads to an overestimate of the anti-10A level in the laboratory. So we cannot use those. So after we've given Andexanet, we can't measure the anti-10A level and say, oh, it's worked, because we will get an overestimate of the anti-10A level due to the way the standard anti-10A assays are performed in the laboratory. So I've talked about the laboratory side of Andexanet. What about the way that in the trials, how its clinical effect was assessed? Now, I do not expect you to read this table here, but basically to be able to determine the hemostatic efficacy of Andexanet, you had to meet specific requirements. So for example, let's look at intracerebral bleeding, intracerebral hemorrhage. For the drug to have been, for Andexanet to have been excellent or good in its effect, the hematoma present in the brain had to not have increased too much in size. To show there's been no effect at all if the hematoma had increased greater than 35% in size on scan compared to when the patient first arrived in department before they got Andexanet, that was considered as no effect. Now, and again, there's other complicated ones showing here at the bottom. If someone had bleeding that might lead, that might cause them to drop their hemoglobin, you could see what the drop in hemoglobin was and whether that drop was kept to less than 10% from baseline or more than 20% from baseline to work out whether someone was excellent, whether Andexanet had an excellent effect, a good effect, or no effect at all. Now, a lot of us have said in thrombosis and anticoagulation circles, can we really say that Andexanet is effective when you give it and the hematoma volume of an intracranial hemorrhage doesn't increase that much? To be fair to the trial organisers, this is strongly based on the hemostatic efficacy that was used in the prothrombin complex prothrombin complex concentrate versus fresh frozen plasma for the coumarin reversal trial. It's basically now being used as a benchmark for safety and efficacy of other reversal anticoagulants, and this is the justification for this being used. We can discuss whether we feel that this is appropriate. So, and what was the feeling? I've talked about what the parameters were for assessing whether effect was excellent, good, or poor. What did patients achieve? This is based on much more objective terminology than, say, was used in the Idarucizumab trials. So, sure enough, in the 204 patients that were assessed, 82% had an excellent or good hemostasis response at 12 hours post-infusion. And this didn't matter what drug you were on, what your gender was, and where you were having bleeding problems, as shown in this figure at the side. So what makes us hesitate to give Andexanet? Because that is my personal experience, the experience of many people in my health board and also around the country. We give prothrombin complex concentrates pretty readily. Idarucizumab, we were giving it readily when we were still using a dabigatran, but obviously not so much now, just because we don't see the use of dabigatran being very high. And yet there's lots of head scratching with the use of Andexanet. Now, why is that? Because hopefully you can see from the evidence that I've shown you so far, all the trials have a little bit of an issue. So let's now think about what reversal agents out there and what we'd like to see in them. Going back to that very first talk, how have they been assessed in clinical trials? Do they work? Are they easy to give? Do they have a fast onset? Do they have a similar half-life to the anticoagulant that they're trying to reverse? Are they prothrombotic? And how expensive are they? So when it comes to the evidence then, if we take these one by one, randomized controlled trial, there was a randomized controlled trial of how effective prothrombin complex concentrates are at reversing coumarins, such as Warfarin. That was done 10 years ago, and it showed that PCCs are more effective than FFP. Idarucizumab and the Andexanet trials were both open label, so no comparison arm, which has always given people pause for thought. Are they effective? Well, hopefully you can see, so as far as we know from the randomized controlled trial in 2013, yes, PCCs are clinically effective at reducing the effect of warfarin. When it comes to Idarucizumab and Andexanet, there's pretty good evidence based on laboratory assays that these drugs work. And it's highly surprising. We know how they function. They seem to be targeting this specific problem that has been created by taking the anticoagulant. That makes sense. But their effect on patients is much trickier. In the Idarucizumab trials, it was purely subjective assessment of bleeding. Andexanet really did trial those trials. They had an objective assessment of bleeding. Whether we feel that is a good objective assessment of bleeding is up for discussion. And one of the things just to talk about the ANNEXA 4 trial is the pivotal trial about assessing the effect of Andexanet to reverse oral 10A inhibitors, is that the exclusion criteria for intracranial hemorrhage, I just really want to bring this to your attention, is very, very precise. So if a patient's Glasgow Coma scale was less than 7 when they had an intracranial hemorrhage, or the intracranial volume was more than 60 cubic centimeters, you couldn't be in the trial. And the question is this really the real world? And then there's another pertinent result that I think is important to just consider when you're using Andexanet, is patients who had poor or no hemostatic efficacy on using that objective table I showed you. Those patients with poor efficacy had similar reductions in their anti-10A level activity as those with good, excellent efficacy, which just has to bring in question, what is the clinical effect of these drugs, even though their biological mechanism and the measurement of anti-10A activity would suggest that they should be effective. About being easy to give. Now, they're all boluses and IV infusions. Certainly giving PCTs and Idarucizumab is pretty quick. It's a little bit more complex with Andexanet. You have to give a bolus and you have to give an intravenous infusion, and that takes 2 hours. And I think that's been one thing that's made people think, oh, how do I give this? And I think one thing to just point out here, some of you may have heard of the Rapido trial. It's not published yet, but it's been talked about at quite a lot of conferences, is that dosing is a little bit complicated with Andexanet. You've got to look at what dose the patient's on when they last took it, and you've got to set up the correct bolus and the correct infusion. The Rapido study, which looked at the reversal of all types of oral anticoagulants, showed that with Andexanet dosing, we were only getting it right in about 2/3 of cases, which shows that we're not quite certain exactly what we're doing in that emergency situation when it comes to dosing Andexanet. Next big question is, does the reversal agent we're using have the similar half-life the anticoagulant it's trying to reverse? Now, BCCs for warfarin reversal, it's a little bit tricky. PCCs, they have those 4 factors in them. They have half-lives that range from a couple of hours to, more than a couple of days. So to a certain extent, warfarin is reversed by PCCs based on the half-life, but to a certain extent it's not, hence the need for vitamin K. Idarucizumab does have a similar half-life to dabigatran, around about 12 to 24 hours. Andexanet has a half-life of about 2 hours, and hopefully I've shown you that we could see the anticoagulant, the reversal effect of Andexanet wears off pretty quickly after the infusion stops. And we know that the half-life of the 10A inhibitors that Andexanet is working against generally have a half-life of about 11 to 12 hours. And you can perhaps see this from this graph here. So this is assessing the effect in the ANNEXA trial, assessing the effect of Andexanet on people who received apixaban and rivaroxaban. Now, at the end of the bolus, the levels of anti-10A have decreased hugely, but the levels do start to increase significantly by 4 hours post-infusion. So you can see that, the levels are a little bit lower. Certainly for rivaroxaban, they're a little bit lower than they were at baseline, but they are certainly starting to come up again. Are any of these reversal agents prothrombotic? Now, this is a really, really difficult question to answer, because if you're going to stop someone's anticoagulant, then their risk of thrombosis is going to increase. In the PCC trials, reversing warfarin, the rate of venous thrombosis off the anticoagulant was about 3 to 4%, a little bit higher on adarucizumab, and then higher again still on Andexanet. Now, is this just the population that was studied, or is it something else? And so there's a few things just to consider here. So the trial results, the thrombin generation studies were done, and there was a significant increase in thrombin production after the bolus and infusion of Andexanet, about 30% higher than baseline, even at 30 days after Andexanet was given. Also, in this same healthy volunteer population, there were increased markers of coagulation activation after receiving Andexanet. So we have a few ways of measuring that: prothrombin fragments, thrombin and thrombin complexes, and D-dimers. They were all increased. And not only do we know that, but we also know that Andexanet, I don't think we're quite clear on the mechanism, but Andexanet also seems to decrease inhibitors of coagulation, for example, tissue factor pathway inhibitor. That's a major inhibitor of the factor 7 tissue factor complex that's essential to stimulate coagulation. So if you're trying to reverse the effect of anticoagulation, you don't really want to be decreasing the inhibitors of things like tissue factor pathway inhibitor, because you may be making that patient more prothrombotic. Now, this is all theoretical. We do know that TFPI is decreased, but is it possibly related to why there might be a slight increased risk of thrombosis in the Andexanet trials compared to, say, the PCC trials? They're obviously not direct comparisons, but again, it's just something to consider. And then finally, the expense. This shouldn't matter, but I think it's something that we do think about. And Andexanet is certainly more expensive, even though this is just approximate. We can't be for certain how much these are actually costing the NHS. But overall, Andexanet is probably the most expensive. So it makes you think, and this is what we did to begin with, was before we had Idarucizumab and Andexanet, we were using prothrombin complex concentrates with the dabigatran and also with the 10A inhibitors, but we stick with the 10A inhibitors to begin with. When healthy volunteers were looked at in these early clinical trials, the prothrombin complex concentrates did seem to normalize the prothrombin time in healthy volunteers taking rivaroxaban. A study was done on patients taking edoxaban, rather healthy volunteers taking edoxaban, and if you gave PCCs, it seemed to reduce bleeding and normalize thrombin generation when doing a punch biopsy. But the recent publications really conflict. Take it to a real extreme is that if you've got someone on a 10A inhibitor and you give PCCs compared to doing just stopping the drug, there was no improvement in outcome from major bleeding. And then even trickier, one study, a retrospective cohort, has shown better outcomes in intracranial hemorrhage with PCCs compared to Andexanet. But then there's another two cohort comparison, again retrospective, where there's better outcomes with Andexanet compared to PCCs. So the jury is still really out about, could we use PCCs? It doesn't quite seem, unlike Andexanet, where you've got a really clear mechanism as to how it works. With PCCs, the mechanism is far less clear. So I don't have any perfect answers. We've certainly got licensed reversal agents out there now for the drugs that we're using most for anticoagulation, I would say, and their effectiveness is biologically plausible. There is evidence of the effectiveness via laboratory assays, but we have to appreciate that there are limitations in the trials in terms of their clinical effectiveness. For both Idarucizumab and Andexanet, there was a lack of control arm, and the subjective assessment of bleeding for Idarucizumab certainly really limits the ability to show that Idarucizumab is demonstrating clinical effectiveness. And I'm just going to postulate why I think there's head scratching with Andexanet in our health board, and I suspect other health boards. The half-life disparity between Andexanet and the anticoagulants reversing. Andexanet has a much shorter half-life than the anticoagulants. It's a complex administration. There is a clinical concern about thrombosis risk. It's very hard to tease out, but I think it's there, and there are potential laboratory evidence that there is an increased thrombosis risk. And then in the back of our mind, there's always the cost. Should we perhaps just use PCCs, perhaps as less thrombotic risk? It certainly costs less. It's easier to give. The half-life disparity is probably less, but the actual mechanism of PCCs is a little bit counterintuitive, because you would think that certainly the 10A in that would seem to be inhibited by the direct oral anticoagulant you're trying to reverse. So real-world assessment and audit remains incredibly important, and I think we should await the Rapido full results, which should be forthcoming soon. We certainly, in the meantime, need to give education regarding the correct dosing of Andexanet, because we're obviously not doing it well, looking at the initial Rapido results. And there are ongoing trials on Andexanet. At last, there is an ongoing trial looking at intracranial hemorrhage using Andexanet versus standard of care, and be very interesting to see what the outcome of that is. There has been a trial of reversing 10A inhibitors with Andexanet for surgery, but unfortunately it was terminated early. I think from what I can read, because there was no comparator arm. So I'd like to thank you very much. I hope I haven't run over my time.